Hello, everybody, and welcome to the Tuesday edition of Video Clips. And before I get into today's topic, just a couple of things I want to remind you about. I'm still doing intro sessions via conference call on for professional development, like people who are in the healthcare business and not happy with healthcare and saying, what am I going to do with myself next? And anyway, the next one of these is April 7th. It's a Thursday night at 9 p.m. Eastern. It's free. Limited participation because I can only have so many people on a conference call. And then I'm teaching a couple of sample classes. Like if you've decided that you're maybe thinking about professional training with us and you're just a little uncertain, like, what am I going to learn and how does it work and what kind of assignments am I going to get? I'm going to do a 2-hour workshop for health professionals on March 28th at 7 p.m. Eastern. And then on Tuesday, April 5th, I'm going to do another one for people who are possibly interested in our nutrition educator program, which is an alternative to conventional dietetics. And so what does it look like to become a nutrition scientist? What kind of research do you do? How do you find things? What am I going to learn again, right? So limited ability to participate, free, but I can only have so many people on a Zoom or a conference call. So let us know if you want to participate. And then the last thing is Monday, May 9th, Nutrition and Immune Function Boot Camp. And I'm going to cover diet and supplements and how they interact with your immune system. Timing is right. Obviously, people are interested in this kind of stuff, right? So, but what I want to talk to today, the topic du jour, is breast cancer. There's a growing realization, even in the conventional medical community, that overdiagnosing breast cancer is a problem. It's due to screening practices, and the impact is as much as 15 to 20% of breast cancers really probably shouldn't be categorized as breast cancer at all. So mammography screening is what results in this situation that everybody's becoming increasingly concerned about. So I want to talk a little bit about mammography and current recommendations and all that. So we'll start with the American Cancer Society, which currently recommends that women 40 to 45 have the option to start screening with a mammogram every year. 45 to 54, every year mammogram. 55 and older, you can switch to every other year or continue yearly mammograms. And then as long as a woman is in good health and expects to live for 10 years, she should keep doing this into perpetuity. But here is the problem. Mammography often misses aggressive tumors that grow between screenings. We call those interval cancers. And I think almost everybody knows somebody who had a mammogram in February and by the end of the summer has a tumor, all clean in February, and then a palpable tumor. Women find them when they're taking a shower and that kind of stuff. So what the heck happens where you miss it in February and it's full blown enough to detect on your own by August? Well, that's an interval cancer. And those are the ones that are aggressive and problematic. Mammography does detect small benign tumors like ductal carcinoma and Situ that usually are not cancer at all and sometimes referred to as pseudocancer. And a few of these pseudocancers develop into cancers requiring treatment, but that doesn't mean that women don't get treatment for them. All right. So ductal carcinoma in situ is the term that we use. It's the most common type of non-invasive breast cancer. Ductal means the cancer starts inside the milk ducts. In situ means in its original place. And it's considered non-invasive specifically because it hasn't spread beyond the milk ducts into the surrounding breast tissue. In fact, sometimes it's even referred to as stage 0 cancer. The cells have cancerous qualities, but they're not cancer yet. Most important, and this is what women are not told, is that they usually do not develop into full-blown cancer requiring treatment. Studies of thousands of women who had breast biopsies in the 1950s and 60s and were untreated show that the risk of developing invasive breast cancer or dying from it is actually low. In a cohort of women in Tennessee, only 25% of women with DCIS developed invasive breast cancer within 10 years of their biopsy. And another cohort of women in Italy, only 11% of women developed invasive breast cancer in the 20 years following biopsy. This means that 82% of women didn't develop breast cancer. And for those who did, invasive cancer developed over a period of several years, which means that it would not be unreasonable to look at active surveillance combined with changed habits as a reasonable alternative rather than treatment. The diagnosis of DCIS is increasing. There are tens of thousands of diagnoses every year in the United States, and DCIS constitutes about 18 to 25% of all newly diagnosed breast tumors. The current recommendations are lumpectomy with localized radiation for follow-up treatment, but more and more health professionals are advising women that this might be over-treatment. The risk of developing metastatic cancer or death for a DCIS patient is less than 1%. In fact, the risk associated with DCIS is similar to other risk factors for breast cancer like obesity and diet. Women actually are not suffering from an epidemic of breast cancer. You see a lot of scary statistics that indicate that, but they include these DCIS diagnoses. They're actually suffering from an epidemic of screening. And a very interesting critic of all of this is Dr. Laura Esserman, who's a professor at the University of California, San Francisco Breast Cancer Center and co-leader of the breast oncology program at the UCSF Helen Diller Family Comprehensive Cancer Center. So this is a breast cancer surgeon who's very embedded in conventional medicine and basically says DCIS is just one risk factor of many. She says aggressive treatment does not improve outcomes, and there's no evidence that radiation reduces mortality, but considerable evidence that it can cause harmful side effects. And by the way, the objective of any screening program should be to reduce mortality. And if it doesn't do that, it's an ineffective screening tool. So mammography continually resulting in diagnoses of 18 to 25% of these are not cancer, but being treated as cancer. This is where some of you have been watching me or listening to me for a long time. You've heard me say that mammography hurts more women than it helps if you look at the data. So the bottom line is I'm not here to tell people, you or anybody, you should or you should not have a mammogram. Now, I don't have an agenda that way. What I'm talking about is that women should carefully consider the risks associated with screening mammography, which include overdiagnosis and overtreatment. And one of the reasons that this has to be considered is that it's all well and good to say, well, if they find something like DCIS, I just won't do anything about it. But the reality is when they find something, women, men, everybody gets kind of sideways about it. And then there's a lot of pressure from family and friends to get treatment. That's where the overtreatment comes from. So, you need to think about it before. Mammography does not reduce the risk of dying of breast cancer, which is the only justification for screening programs, and it can bring on a whole lot of grief like what I just described. So, and there's one other insidious thing about all of this screening that we do. And by the way, only one screening test actually does reduce the risk of dying of cancer, and that's cervical cancer screening, PAP test. So this is to be very specific. So there's only really one thing we should focus on, which is optimal diet, optimal body composition, exercise, limiting alcohol consumption, containing and reducing stress, and living a health-promoting life. That's what reduces the risk of breast cancer. And so I started to say, got a little off track here, but what makes me crazy about some of these screening programs is that they distract from that. In other words, what the honest statement, if doctors and medical professionals would make it, is we don't have a screening tool right now that detects breast cancer early and prevents you from dying of breast cancer. If women heard that, many of them would be more motivated to do the things that really can reduce the risk of dying of breast cancer. And the constant pressure to get mammograms is intense. For example, I get letters from my insurance company all the time telling me to go get a mammogram. Nowhere in these notifications is anything about how to prevent breast cancer death or to prevent breast cancer, period, right? So we need to get the focus away from screening, testing, and get the focus on what do you have to do to prevent, what can you do to ratchet the risk down as much as humanly possible? And it's those diet and lifestyle factors that I mentioned before. So again, I don't have an agenda here, and I'm not here to talk somebody out of getting a mammogram who wants to get one. Or out of anything else that they want to do. I am for informed medical decision making. Have all the facts and make an informed decision. That's what I'm trying to promote here. And if you watch this and you say, well, all things considered, having heard what Pam Popper says, I'm still going to get a mammogram, that's fine. Just like people make other decisions about houses and cars and real estate and retirement accounts, all kinds of other things that somebody else might disagree with, but at least they look into it usually before they do it. That's all that I'm saying here. All right, well, that's all for today. As usual, pass this on to anybody who you think would enjoy watching it, and I will be back to you tomorrow with more news, albeit on a different channel, of course. So have a great day. Talk to you again tomorrow.